Okay. Sorry about that. I think my mic was not working. But hey everyone. Let me know if you can hear and or see me. Appreciate it. Perfect. All right. Thank you, Brooke. Appreciate that. All right. Hey, so it's our last week. Boy, things have gone by quickly, but here we are. Thank you. Appreciate all the good mornings. Hello, everyone. Abby, Julia, Savannah, Brandon, Kayla. Thank you all for joining me today. No Dallas. So we're going to go ahead and get started here. A couple questions. Excuse me, came up mainly going over the HIV and STI stuff. No, did we finish the diabetes stuff? I think we did. Let me double check. Yes, it looks like we did. So I think we're okay there. Oh, well, thank you, Happy. I appreciate that. Yeah, it's been weird how fast it's been, but it's been a weird year overall, I would say. But it is what it is. But I'm glad I was able to do this live with you guys this year instead of pre-recording everything. I think that hopefully it's a better delivery method for you all than doing it pre-recorded. We'll see. Oh, thanks. That's really nice of you guys to say. Anyway, so I had a couple questions here regarding some of the HIV meds here. So for the first one here for HIV, will you always do 2 NRTIs, or can you do 2 protease inhibitors plus 1 NRTI? The regimens are generally always 2 NRTI plus something else added on. There's a couple newer regimens where they recommend maybe like 1 NRTI plus something like an integrase inhibitor, but traditionally it's been 2 NRTIs. You'll never do 2 protease inhibitors unless it's using ritonavir boosting something else up, and that's not really considered like not the same as using like 2 NRTIs basically. So sometimes you'll see that 2 protease inhibitors, but it's really just ritonavir boosting up another one. That's the other one is the main one that you're using there for that regimen. So from that standpoint, I would not consider that to be like 2 protease inhibitors. Really just using more of a booster for that. Yeah, so 2 NRTIs are generally the rule. Someone said, sorry, I'm confused. Don't be sorry about being confused. That's okay. This is a confusing topic. He said most protease inhibitors are 3A4 inhibitors, but I saw that lopinavir and darunavir can be boosted by ritonavir. Does that mean that some of those are some that aren't, or do they still get boosted by ritonavir? Yeah, they still get boosted by ritonavir. So even if they're maybe not as strong of an inhibitor as ritonavir, they can still get that benefit. So remember that things can be both substrates for 3A4, but they can also be inhibitors of that same enzyme, right? They can do both. So even though something like lopinavir might have a little bit of an ability to inhibit 3A4, you'll have ritonavir that will then boost that up even further to get levels that are sufficient to maybe not have to take it like, a couple times a day. Things like that. Hey, Maggie and Emily and Brina. Good to see you guys. So hopefully that makes sense in terms of that. All right, so let's see here. Oh, 20 people. That's pretty good. Good. So we have our PowerPoint here. So hopefully everyone's able to get access to that. I don't think there's any. I didn't see anyone have problems getting in. A little bit of a shouldn't be too bad here. So we're going over special populations in regards to kind of the extremes of age. We're going to talk about peds and geriatrics, and this is more so kind of a kind of a survey of these and kind of talking about how we might use some of our medications more specifically in these populations based on sort of the changes that occur with them in terms of their development or organ function and things like that. Hey, Jillian. So let's start with pediatrics first. Pediatrics can be tough for a lot of people, especially if you're not doing it every single day. It can be quite anxiety inducing for some if you've never done it before. But for instance, I do it every single day that I work, and it becomes kind of second nature to you after a while. But why do people get so apprehensive about this? Because you can't just say kids are just little adults. It just doesn't work that way, because they are very heterogeneous in terms of a population, meaning that a 2-month-old is going to be very different than a 2-year-old, and very different than a 2-day-old, right? And they're undergoing these constant physiologic changes. The other thing that's really tough too is it's hard to do, pharmacokinetic and pharmacodynamic data in children because they're sort of a protected class. It's harder to do clinical trials, and you're kind of seeing that now with the coronavirus vaccine. How we started with adults, and then now we're gradually working our way backwards in order to get younger and younger patients approved for use, right? So they'll kind of work for the 16, 18-year-olds first because they're pretty much adults, and then they'll go younger and younger to see basically how safe is it for those patients, how efficacious, and then based off of that, they may say, okay, here's our floor, here's the youngest that we're going to go. So we'll see how that kind of goes as time goes on. In terms of pediatric lingo, it's important to understand how we're talking about the age of these patients here, and some of this might be a bit of a review for you, but that's okay. The gestational age is basically how long the patient was developing in utero, typically based off of dates, things like the last menstrual period that the mom had, or based on things like the physical exam. So, using things like ultrasound, you can kind of see how developed it is and how large it is, and that give you some ideas in terms of the gestational age. Hey, Jillian and Erica. Postnatal age is basically how old they are after they're born, and then there's another term called postconceptional age, which is kind of the two put together. We don't use that one too often in terms of medications, but we use the gestational and the postnatal age all the time. Because the gestational age is basically going to tell us how developed the baby is once it's born, and then the postnatal age tells us basically how old it is now that once it's been born, and so that has that can have a lot of impact in terms of how you're dosing your medications and whatnot based off of that. And I can show you some examples. Typically, preterm is anything less than 37 weeks gestational age. Full term is that sort of 37 to 42. And then post-term would be considered anything past 43 weeks. I don't really care so much if a baby is post-term, but I care a lot more if they are preterm, because that can have a big impact in terms of their organ development. Once they are born, we will consider newborns or neonates to be the first 28 days of life, or basically that first month of life there. And then an infant is really anything during that first year. So you may hear me sort of use the terms. You may hear me call a newborn an infant, which is technically correct, but it would be incorrect to call, a 10-month-old a newborn. That doesn't make sense. So kind of like a squares and rectangles kind of thing there. So just know if I say newborn neonate specifically, I'm talking about that first month of life. So we can look at some of the different changes that are happening here in terms of organ development and things like that, and how that'll affect the different pharmacokinetic principles we've talked about. So the absorption, distribution, metabolism, and excretion. And we'll see sort of the changes that happen here during normal infant development, right? So in terms of absorption, things that affect this from a drug standpoint can include things like molecular weight of the drug. So smaller drugs are going to be able to cross easier across membranes. Particle size as well. Talking about things like pH and pKa. If you recall, we talked about that towards the beginning of last semester. We'll get into that in just a little bit and how that affects charge of medications and whatnot. And then the dosage form itself. So is it coming as a cream versus an ointment versus a tablet, things like that. And then also the big changes here that happen with peds is going to be the actual anatomical and physiologic characteristics of where you're actually applying the medication. Is it to the skin and the muscle and the veins? Where are we actually giving the medication? So let's talk about gastric absorption first, because this is ideally the most common and safest way to give medications. Typically, we're going to see two big things that affect the absorption of medications. Includes the gastric acidity and also the gastric emptying time. So how fast are things moving through the GI tract, and then how acidic is it going to be? And again, this differs pretty greatly between infants and adults here. What you're going to find is that typically when you have medications being affected by the pH of the solution that it's dissolved in, right? So remember we talked about pKa and pH and how that can affect how well things are how soluble they are in a given solution, how easily they cross a membrane. You see that the changes in the pH here can be a factor of both how developed they were when they came out. So if they were preterm versus term, typically you'll have an increased pH in the GI tract for a preterm infant because they weren't really ready to be born yet, so to speak, and so their GI tract wasn't really developed enough to be able to produce acid because it wasn't made to take in things orally. I was still expecting to be fed through an umbilical cord for a while, right? we'll see that as gestational age goes up, then gastric acid production will go up as well. So as they get closer to term. Typically, you're going to see that the gastric pH for the first couple of days after they're born is actually pretty neutral, and that's because they've been passively sort of absorbing amniotic fluid from the mom for that, basically the term of the, while they're in utero. And so it takes a couple of days for them to sort of work that out and then start to produce their own acid to get down to sort of closer to natural levels. And you'll see that they'll sort of approach that adult values as about 3 months or so. But before that, you're going to see that it can have some major effects in terms of how drugs are absorbed. So as an example, if you have like an acidic drug, so say for instance you need to give aspirin for some reason, you'd find it would have increased ionization because the GI tract is more basic. It would have decreased ability to be absorbed. So maybe you would have lower blood levels versus a basic drug. If it's in a more basic medium, like here, if you had like a preterm infant, it would have decreased ionization, so it would have an easier time getting across. You see more absorption. So again, it can be very dependent on the drug, and oftentimes when you're looking this stuff up, say you're looking up on Lexicomp or something, and you're on the neonatal section, they will account for this. It's not that you need to sit there and think about, okay, well, is this drug a weak acid or a weak base? The drug dosing is taking this into account, but this is why you see differences between children and adults and infants when looking at the drug dosing. This is why it's so important to make sure you're not just using adult dosing and applying it to a neonate. That's not going to work, right? The gastrointestinal transit time or emptying time is also going to be a feature here. We're going to see that the GIT is going to be much shorter in infants less than 6 months of age. If you've ever dealt with an infant or maybe you've had one yourself, you will find that they do have quite frequent bowel movements compared to kids that are a little bit older. So they may have a couple of times a day they're having a bowel movement because things are just moving through so quickly. And that may mean that drugs are less easily absorbed because they just don't have less contact time with the GI epithelia. This can also be affected by several things. So for instance, anything decreasing blood flow to the gut can slow this down. So for instance, congenital heart disease, right? Things like the type of feeding they're getting, whether they're getting breast milk or formula or what type of formula they're getting. And then again, the gestational and postnatal age can affect this as well. So again, as I mentioned, we don't see a lot of controlled release preparations of medications that are designed to be absorbed over 12 or 24 hours because they would just be expelled way too quickly from a neonatal or infant GI tract there. So again, shorter transit time decreases that duration of contact with those absorptive surfaces. And again, depending on the age of the baby, depending on the gestational age, it's going to affect what their actual serum concentrations might be, and that accounts for sort of that intra-patient sort of variability. So let's look at some other ways we can give medications here. We'll look at things like sub-Q, intramuscular, and then transdermal medication administration, how this can be affecting neonates versus infants versus children. You're going to see here that typically this is most important during the first month to year of life, and then by the time they're kids, by the time they're two and above, you'll find that they will, or I guess 1 and above technically, you're going to find that they're going to be pretty close to adult patterns for the most part. But we'll see some of the factors that go into that. I always love it, especially when like you're talking about kids when they're first born. They're like, "Oh, how old is your kid?" And they're 10 months old, they're 11 months old. And you have the people that kind of take it too far, and they're like, "Oh, they're 84 months old." It's like, what? 84? That's crazy. We'd always do that at the Poison Center. We do up to 24 months, and then after that, they were like, they're 96 months old. It's like, I don't care. Just tell me they're 5 or whatever, however old they are. Anyway, so getting into intramuscular absorption, this can be dependent on several different factors here. So one, how much blood flow is actually getting to the area of injection. If there's not a lot of blood flow, it's not going to be picking up a lot of that medication that's just hanging out there in the muscle. The rate of drug penetration also can be a factor here in terms of how lipophilic it is. And then the apparent volume of distribution. We're going to see, especially with neonates, they tend to be, I kind of equate them to big bags of water, right? They're very, they don't have a lot of muscle, they don't have a lot of fat, but they do have a lot of water in the tissues, and that can affect the volume of distribution, especially for hydrophilic meds here. Also, you're going to see when a neonate's first born, they're not really that mobile. They're not getting up moving around. They're usually swaddled up and bundled up, and that means they're not getting a lot of blood flow through the muscles because they're not moving very much, right? As I mentioned, there's a lot of water in the muscles here and less contractions, which basically overall means they're not going to be absorbing quite as well, or you may have slowed absorption overall. And you can see as well that they'll have this peripheral vasomotor instability, which also means they don't regulate their temperature super well, which is why they're typically swaddled up and have a cap on their head and all of that. And that can affect, vasodilatory sort of actions and may affect the drug absorption as well. So again, it's pretty variable, and it may be slowed in a lot of cases there, especially the younger the kids are. Other ways we can give medications include rectal absorption. So this is a good way to get medications into kids because the rectum itself is highly vascular. It's a thin membrane, pretty easily able to absorb medications there. You get good mucosal translocation. However, you always want to consider, and again, we do this a lot for like acetaminophen suppositories and things like that, because they do have an increased number and amplitude of the rectal contractions, it's easy for suppository to be placed and then it be expelled right out into the diaper, for instance. So in some cases, it's handy to have parents make sure they kind of insert the suppository and then kind of hold their cheek shut for just a couple minutes, and that will allow for the suppository to melt and then be absorbed, as opposed to just being spit back out into the diaper. And it's not really doing a whole lot of good there, right? Other ways we can do drug administration for kids, because especially with neonates, it can be very difficult to get IVs established. Especially imagine you have a kid who's coming in who's only maybe a couple of months old, and they're in cardiac arrest for whatever reason. They're not perfusing, and those veins are just so small. They're not really pumped up full of blood. It can be very difficult to get IVs established. And so instead what we can do is intraosseous drug administration here. And this is basically where you can take, a needle, be able to insert this into the marrow of the bone, and then apply. You can give all your medications through that. You can give fluids to that. It's like a big non-compressible vein, basically. Very useful for emergent situations where you can otherwise not get an IV. Here's an example of something called an easy IO, which is very handy. You'll see this in a lot of emergency rooms and ambulances and whatnot, but basically there's different needle sizes that look like big thumbtacks, basically, and based on the age of the patient, this is what size you'll pick. So obviously this would be for like the infants. You can do it at the tibia, you can do it at the sternum, the humerus. There's a lot of different places you can do it potentially, and again, very handy to get medications into your patients for sure. So in terms of transdermal or percutaneous drug absorption here, we're going to see that kids typically have pretty thin skin. Not about their ability to take an insult or something, but more so the fact that their skin is just underdeveloped, right? The stratum corneum is not really as thick as you would see for older children or adults, and this can lead to inadvertent drug absorption, right? So you can see that the thinner the membrane, the easier things can be absorbed. So as an example, we talked about, I think we talked about thyroid pharmacology previously. You can see here that we can have betadine, which is a disinfectant, has iodine in it, and you can actually apply this to a kid's skin. They can absorb enough of the iodine where it can actually cause hypothyroidism, which wouldn't be a problem for adults, but it is a problem for these little kids. Joe was asking, does that mean you'd have to leave the needle in so you can give multiple doses with IO, or you need to do every time they need a drug? No, those the IO can stay in place for a while. I'm not sure how long. I've never seen it needed past maybe an hour or two based on the situation, but we would typically see, say for instance, like someone came in from EMS, they had the IO in place. Once we were able to get more definitive IV access established, then we would take out the IO basically. But no, you can leave that in place. It has a line that will be attached to it, and you can apply medications through that. Like I said, fluids, drugs, whatever you need to do. Blood, I think, can go through there. Yeah, you can get everything through that. We actually had one time, I had an adult patient who had an IO in places in their sternum, and they were they're in cardiac arrest, and so we were unfortunately unable to get them back, so they died, and so they're getting the patient prepped for the family to come in to see them. And so they're trying to get the IO out, and so normally it kind of just, you can not like unscrew. It's not like screw. It's not like threaded like a normal screw would be. But they're trying to pull it out, and unfortunately the plastic bit came off and just left this like big needle sticking out of the patient's chest. And so it was like, ooh, that's not good. So I think we ended up having to find some pliers or something to be able to remove that. It was not the most elegant thing, but that's a rare complication with that one. But not fun. Anyway. So as I mentioned, they have things that can be absorbed pretty well. They have very well hydrated skins, well perfused. So again, you can see pretty good absorption there. Also, just their body surface area or the ratio of their body surface area to their mass is a lot bigger than you're going to see with adults. So even covering a relatively small amount of surface area can be quite a lot for those patients there. So you do have to be careful. So as an example, using things like Benadryl lotion can cause anticholinergic toxicity in those kids. Or if you're back in the day, they used to use isopropyl alcohol or isopropanol baths to wash these kids off, and they would actually end up developing lethargy and hypoglycemia because they're absorbing that alcohol through the skin. So again, not something you see with adults, but these kids have very thin skin. They're much more able to absorb that. So that's absorption. Let's talk about distribution here. So things that generally affect how distributed drugs will become in the body include things like lipid solubility of the medication. We're going to see the plasma protein binding, meaning is it like to bind to the proteins in the blood, or is it like to bind to proteins out in the tissue? That can have an effect there. And then the peripheral tissue distribution overall is what we're going to be looking at here. So looking at a newborn infant, as I said, they're kind of like a big bag of water. So they're like 70 to 75% of their body weight. They're going to have a kind of a beefed up extracellular water component there. They also have less fat tissue and less muscle tissue. What that means is that for hydrophilic medications, they're going to have a much bigger volume of distribution. And then conversely, for lipophilic medications, they're going to have a smaller volume of distribution. So what does that mean for our drugs? Well, it means that you have to adjust the doses that we're giving in order to achieve the same concentrations that you would want to get for like an adult patient, right? Because again, if they have like an infection, we're shooting for the same concentrations. It's just a matter of how do we dose it to make sure that we get the same levels for the patient, right? Basically, you can kind of consider kids to have a much bigger bucket to fill with hydrophilic medications than you would see for an adult med. So what that mean, or for an adult patient, what that means is to get the same concentration, I would need to give a much bigger milligram per kilo dose for the peds patient than I would for the adult, because I have a larger bucket that I have to fill. Okay, even though the dose might be smaller than an adult, on a milligram per kilogram basis, it is bigger. And I'll show you an example of that here in just a second with gentamicin. So if you look at the actual dosing here versus the volume of distribution, for instance, gentamicin is an aminoglycoside antibiotic, very hydrophilic. You see the volume of distribution is about 2 to 3 times higher than you would expect to see than an adult might be, or even an adolescent. So that means the dose you have to give is 2 to 3 times higher, basically, by giving 4 to 5 mg per kilo per dose, as opposed to say 1 to 2 for an adult. So just an example, I have to give a bigger dose to get the same concentration as the adult because I have a bigger apparent volume that I'm trying to fill, a bigger bucket to fill, so to speak. So that will then come into play when we talk about our metabolism and excretion, when we talk about how often we're giving the drugs. But overall, you may see you need bigger doses for these peds patients than you do for an adult. And this is why, right? And that's why it's really important that when you're looking at the drug dosing information, that you're looking specifically at the right section. So if you're dealing with a neonate, look at the neonate section. Dealing with a peds patient, so anyone older than one, or older than that first month, then look at that peds section, right? Other things we can see in our pediatric population includes, as Jillian saying, and that's because of how much water weight they have when they're born. Part of it's due to that. Part of it's just due to the fact that they just naturally have a higher extracellular water content for the first, couple of months of life or so. Part of and again, you'll see that too. Once a baby is born, they will typically drop some weight after the first day or so because they're diuresing a lot of fluid that they had from the mom, but they will still have that increased extracellular water content for a couple of months maybe, and so that will then change as they start to develop, and that's why you'll see the dosing between neonate versus infant might be a little bit different, and that's because of those changes in volume distribution as they develop. So you can kind of see those changes when you look at some of the dosing info. But anyway, so again, other things that can affect this include lower plasma protein levels. That may mean that things are kind of distributing out because they're not being bound up in the actual bloodstream, for instance, like to albumin and things like that. Or you might have things actually competing for the same binding site, like bilirubin. So as an example, like you cannot give the drug Rocephin or ceftriaxone during the first month of life for neonate. The reason for that is because it binds to the same, or competes for the same binding site as bilirubin. So if you gave ceftriaxone to kids during that first month, it would kick that bilirubin off of the albumin, and then you could have a kid develop jaundice, right? They'd have hyperbilirubinemia because it is now unbound, circulating in the blood. Or for instance, you could have drugs like phenytoin have higher free fractions. Normally phenytoin's like 90% protein bound. Well, there's not as much protein to bind to, then it may be say 85% protein bound or 80% protein bound. That means there's a lot more drug that's free and available to interact with things like the CNS, which could cause toxicity potentially. So don't memorize the slide here by any means, but just give you some examples of how things will develop and change as a child develops here. You can see some of these will be, after the first month of life, be pretty close to adult levels, right? But during that first month is where you're going to see the most variability, and that's why you got to look specifically at the neonatal dosing info that you might have available in your different drug references. So moving over into metabolism, what are some things that can affect this? Well, this can include things like gestational and postnatal age, things like how much hepatic blood flow do we have happening here, how about the quantity and quality of the enzymes that they have. Not every hepatic enzyme is present during that first month of life necessarily. And then other competing factors like, do they have liver disease? Do we have enzyme induction or inhibition? These can all play a role in how well things get metabolized. If you recall, back during our first couple of lectures, we talked about phase 1 versus phase 2 reactions. Phase 1 reactions is basically where we're modifying the molecule to either become more water soluble or to get it prepared for like a phase 2 reaction. This is where we get into our CYP enzymes with the oxidation step, right? So that's probably the most important one we've talked about, but can include other things like reduction and demethylation and things like that. So just to give you some examples of some of the changes that occur during that first month of life, we can see here that the P450 system is probably about, in a full-term infant is only about half as active as you would see in an adult patient. So they're metabolizing stuff potentially half as fast as an adult patient. So that's important because that can affect how frequently we need to give medications here. In some cases, you may see these enzyme systems become overactive. They may be more active than in an adult patient. So as an example, with phenytoin, the oxidation step, by 1 year of age, they may actually be able to metabolize it 2 to 5 times faster than that of an adult. This is why things change. It's important to go back and look at the age of the patient that you're dosing to see if you need to make adjustments as time goes on. In other cases, you may see that they have reduced enzyme capabilities. So for instance, some of the local anesthetics like procaine or tetracaine may not be metabolized as quickly due to the fact they have less plasma esterase when they're infants. And it takes time for them to develop that. So you may see more chance for toxicity or longer half-life during that first month or so, right? Just some other examples of specific CYP enzymes here. So within birth, 2E1 tends to, upregulate pretty significantly there. 3A4 is present within the first month or so. So again, it takes time for these things to sort of develop, and not everything is going to be present right as soon as they come out of the mom necessarily. Again, I don't care that you memorize these specific facts here. It's just to know that this is why the drug dosing is so different. It's because it takes some time to develop a lot of these CYP enzymes. Just like everything else is developing, their liver enzymes have to do that too. For phase 2 reactions, this includes where we're adding something on to the molecule to make it more water soluble, to either be excreted out into the kidneys or into the bile. This includes things like adding a sulfate group, or adding a methyl group, or conjugating with things like glycine or glucuronide in order to make it more water soluble here. And again, a lot of variability that can happen here. However, some of these may actually be overexpressed early on. So for example, with sulfation, kids typically have a really well-developed functional pathway. So when I get calls at the poison center and they say, oh, my kid drank an entire bottle of Tylenol, I actually have a higher threshold for when I start to get worried about that patient from their liver standpoint than I would for an adult. So as an example, if someone called up and they said, oh, my 2 or 3 year old got into a whole bottle of Tylenol, and I calculated out the dose they got. For a kid, if they got 200 mg per kilo, that's when I get concerned and send them in for evaluation. And for an adult, if it's 150, then I send them in. So my threshold's a lot lower for adults because their sulfation pathway is not as good as some of these kids here, just as an example. Other things maybe like with morphine, their ability to glucuronide conjugate is going to be lower, so it takes some time to be able to build that up to be able to metabolize morphine more quickly. Or as a really good example here, glycine conjugation. This is something you'll see in the NICU. When you're looking at IV drug products, there's some that will be single dose and there's some that are multi-dose. multi-dose products typically have preservatives in them to keep them sterile and stable during the period of time when you're using them, right? So you get multiple doses out of it for different patients potentially. They're usually, one of the preservatives you'll find in that includes benzyl alcohol. Well, neonates can't really process benzyl alcohol very well, and so they end up developing this really nasty acidosis. They get this gasping syndrome that happens as a result of that, and so kids have died because of that in the past. So that's why if you're ever on a NICU or if you're on a neonatal unit, you're going to find there's never any multi-dose products that are used there for the most part because they don't want to use any accidental benzyl alcohol exposures to these kids here because they just can't process it. In terms of excretion, we're going to see here that it takes time for them to develop the number and quality of the glomeruli and ability to be able to reabsorb and secrete medications into the renal tubules. Obviously, being premature is going to have patients with much less developed kidneys than you would see if they're born at term. And so this can have a big effect in terms of how frequently we're giving medications. And I'll give you another example here in just a little bit. Now, when you're looking at the GFR for an infant, you're going to see that their serum creatinine is actually going to be not super useful like you would see for an adult in terms of determining their creatinine clearance. So for most adults, you can use that Cockcroft-Gault equation. You can use their serum creatinine, their age, their weight, and figure out what their GFR is basically in order for using for drug dosing purposes. With infants and neonates especially, you're going to find this is not super accurate. One, their serum creatinine is going to be elevated during the first week. Because, and you're like, well, why is their serum creatinine elevated? Is it because they're having a lot of muscle breakdown? Is it because their kidneys aren't working? No, you're measuring the mom's serum creatinine, right? They've been in equilibrium during that 9-10 months they've been in the womb. So that's what you're actually measuring. And over time, it takes them a while to clear that out. But during that first 1 to 2 weeks or so, you're going to start to see that renal function start to perk up and we'll start to start to take over. We don't have a lot of good calculations that we use for neonates, especially to estimate our GFR. So oftentimes what we're going to use is their urine output. So just to give you an example, if we're looking to see what a good urine output is for a neonate, anything greater than 1 ml per kilo per hour is a good urine output. Some of these kids will get up to like 4, 5, 6 mLs per kilo per hour, but as long as it's greater than 1, that's usually pretty good. Typically for adults, you're looking at something like 0.5 to 1 is considered to be good urine output. So just something to kind of think about there. But as I mentioned, preterm infants are going to have decreased GFR, mainly due to the fact they have decreased quality and quantity of glomeruli. They're going to have reduced renal blood flow. All these things make it more difficult for them to excrete these medications here. And again, when you're looking at a preterm infant, and usually you're going to be categorizing them based off of their birth weight, you can see here that, looking at 1 to 2 days, looking at the first week, and then looking at 2 weeks, you can see here that the preterm infant has not even caught up to what a term infant would have been even after 2 weeks, right? Again, especially if you're thinking about kids that are born, 24 weeks gestational age or 26 weeks, like they're very underdeveloped. So it takes them quite a bit of time for their kidneys to sort of catch up because they were meant to be in that womb for much longer, but whatever happened, and so they came out early, right? To give you an idea what their GFR kind of looks like between say like a neonate versus older kids, you're going to see here, even by a couple of months of age, they get pretty close to adult levels here. So this is really the biggest concern in the very early points of age. So again, around that first month or so. So to give you an example of this, what this looks like, you can see here the example of gentamicin. And remember, we talked about with their distribution, we are already giving bigger doses on a mg per kilo standpoint for a neonate versus an adult. But look at the half-life here. So with a neonate less than 1 week, it'll be between 3 to 11.5 hours versus 1.5 to 3 for an adult. What this means is that we have to give the drug less frequently. So we're giving a bigger dose, but we're giving it less frequently in order to get similar levels to what you would see with an adult. Okay. What that means is you may see doses that are higher, but you're also giving it maybe Q24 hours or Q36 hours or Q48 hours because we know they're not going to be able to excrete it as easily as an adult patient might be. So again, that's why I stress to you, if you're dealing with a younger patient, especially a neonate or an infant, look up that specific drug dosing for them because that will take into account the differences in their kinetic fundamentals, right? Differences in their renal function, differences in their hepatic enzyme expression, things like that. Okay. So how do we dose medications for kids? There's a couple different ways you can do it. You can do age-based dosing where you say, okay, kids 2 to 5 get this dose, 6 to 12 get this dose, et cetera, et cetera. This is pretty easy to use in practice because you just look at the kid's age and you say, here's the dose I'm going to give. Pretty easy to memorize. However, this assumes that all of those kids are going to have exactly the same pharmacokinetic profile. They're going to have all the same absorption, distribution, metabolism, excretion. And we know that's just not going to be the case there. Also, you can find kids that can be in the extremes of weight here, and that may lead to kids being either under or overdosed in some cases. So this makes a lot of assumptions and is not quite precise enough for a lot of our purposes. So generally speaking, most of the pediatric drug dosing you're going to use is based off of body weight. Okay, so 20 to 30 mg per kilo per day, or whatever happens to be. This is most common, as I mentioned here, and it works out for most patients because, it is taken into account their actual weight. As a rule of thumb, once they start to get up to doses that are meeting or exceeding the adult doses, that's when you want to cap it out, right? You want to cap it out at the adult doses. Don't go above that just because you happen to have a particularly large kid, right? So, for example, if we have like a football player, so you have a 16-year-old, linebacker coming in and weighs 220, 240 pounds or something like that. Even on a mg per kilo standpoint, their dose might be calculated much higher than that of an adult. You just cap it out at the adult doses, okay? You don't want to overdo it for them just because they happen to be a larger patient, okay? So again, this works for the most part, and you'll see most drug dosing is being done using this regimen here. However, though, we are seeing higher incidences of overweight children. So again, that is a concern. You want to make sure that, again, you don't exceed those adult doses. And again, it's not uncommon to see this pretty frequently. And again, you always want to be careful in dealing with kids to not mix up your pounds and kilograms. Typically, to convert from pounds to kilograms, you take their weight in pounds and divide it by 2.2. And there are some cases there where, I'll actually have to call down to the unit or to the ER and say, hey, wait a second, did you put this patient's weight in as pounds and you meant to put them in as kilograms? And they'll say, no, actually the patient was that big. So again, there's a lot of safety concerns over that if you get those units mixed up, right? You could seriously over or underdose a kid if you do that. So again, just make sure you're consistent. I know most us growing up in the U.S. are probably most used to using pounds, but most of the medical world's going to use kilograms. So just get used to making that conversion there. We can also use body surface area dosing. This is helpful because it not only takes into account the weight of the patient, but also the height of the patient, right? So that way, if you had a particular overweight patient, but they weren't that tall, then they're not going to get as overly dosed as you would see as if you had a taller patient who is the same weight, right? So it's taking into account that's more exact. We will do this most frequently or at least I do this most frequently in oncology for patients who are getting chemotherapy. You'll see most of their chemo drugs are dosed in body surface area because they're trying to get as exact of a dose as possible, and they're able to do this better when they're using body surface area than they would be just using the weight of the patient by itself. So that's one thing to consider there. There's a lot of different calculations, so just wherever you work at, make sure you're being consistent using the same one. There's the most stellar and the Dubois, and just be consistent with everyone you're going to end up using out there. Other thing that maybe something to consider as well is it's difficult to estimate the length of kids in some cases there. So imagine either one, like a kid who had, cerebral palsy, had severe contractures that may be very difficult to get an accurate height. With babies, they typically don't want to sit there and lie still for you to get an accurate height. That can be tough. Even, little kids, like getting my 4-year-old to stand still long enough to be able to get an accurate height on them can be challenging, right? Especially if they have shoes and all on, that can throw it off and all of that. So. Now with IV drug administration, or just a couple of different routes, some of the caveats to think about. IV first, think about the side of the administration you're actually giving, whether you're doing this in a peripheral vein versus a central vein. This can affect a lot of how concentrated of a drug you can give, because of the fact that typically kids' veins are much more sensitive, they're much more delicate than you're going to see in an adult, so you may have to use less concentrated forms of a drug because you don't want to irritate those veins. So as an example, if I have a kid who needs dextrose, they're a diabetic and they need dextrose because their sugar is low, I cannot give as high of a concentration as I would an adult because it'll fry their veins, basically, the vein that I'm administering it through. So for an infant, I can only use D10 versus D50 for an adult, right? You also want to think about the volume of drug that you're giving. It's easy, especially in a very small neonate, that if you're giving a not very concentrated drug, that volume can actually have an effect on things like their hemoglobin and hematocrit concentrations, right? Also, you want to think about things like the mechanics of actually getting the vein in place in the first part. So again, especially with the small kids, especially if they're not very well perfused, you can find that can be very difficult. That's where we talked about the IO administration before. And then just think about things like doing drug sampling like through the blood. Like oftentimes for especially these little ones, you don't want to go back through and do frequent blood sampling, because again that can affect their hemoglobin hematocrit pretty significantly. So oftentimes we're trying to do multiple samples at the same time. So if we can run as much as we can off the smallest amount of blood, that can be really useful in helping to prevent problems there. So with IV drug administration for kids, it's really important to be as exact as possible. And so, for instance, here we have a lot of safety features in place for things like IV pumps that make sure we're not giving drugs too quickly, that make sure they're giving the exact right dose. Because there's been problems in the past where someone will just hang a liter of fluid intending to only give maybe 200 mLs to a pediatric patient, and they end up giving them the whole liter, 5 times overdose. So we want to make sure we don't do that, and so we have a lot of things in place that can help us prevent that. Here's an example of a syringe pump. This is the one we use at our hospital, where basically the pump can tell what size syringe it is, and will basically you program in what drug you're going to give, what concentration, and then this will allow it to then infuse as slowly or quickly as you want. Nice thing about these is we can build in libraries, so that way the nurse can't give things either too quickly, too slowly, too concentrated, and it helps to keep a pretty consistent safety profile and make sure that we're not going to do things too dangerous for a patient there. So very important we use a lot of these safety features and use technology to our benefit for these really kind of sensitive patients. For oral administration, this can be a big challenge because a lot of kids do not want to take medications. So one thing to consider is like the measuring device that you're using. Nowadays, a lot of pharmacies will give you dosing syringes, which are going to be best because those are going to be most accurate. A lot of over-the-counter stuff you can buy will have like a little dosing cup that comes with it, and I can tell you those are inaccurate. I remember I was giving like Benadryl to my kid one time, and I said, okay, I want to see how accurate these little medicine cups are, and it was off by like 2 or 3 mLs. I filled up to the 5 ml line, and I got like a lot more than that in the syringe that I ended up drawing it up into. So if you can use a dosing syringe, that's always going to be best. An oral dosing syringe, I should say. You don't want like a needle trying to jam into the mouth. That would not be great. But also consider things too. A lot of dosing, especially with older people, they are or people have been doing this. From back in the day, they think, okay, we give a teaspoon of this, a tablespoon of that. Go out and get the spoons in your kitchen. You may find there's going to be a lot of variability in that. Especially, I always think about we have some spoons that we bought from Walmart, and they're different than the spoons we buy from IKEA, right? They have different measurements there, and so typically when you think of like a teaspoon, that is 5 mLs, and we think about a tablespoon, that is 15 mLs. But again, if you're using an actual spoon to measure this out, it's not going to be all that accurate. You're going to find a lot of variability there. So that's why I say just use a dosing syringe, and you're going to be a lot better off. Other things to consider are going to be the sensory appeal of the dosage form. Is it in a liquid form that they can actually swallow? Is it something that's going to be something that's palatable to them based off of the taste of it? A lot of pharmacies will have flavoring stations that you can make it bubblegum flavored or banana flavor, whatever flavor they want. They can usually do that for most drugs, but some cannot be changed. But also think about things too, like for instance, we have these melatonin gummies we like to give our kids before they go to bed, and my kids are like, well, this stuff's like candy. Can we have more melatonin gummies? It's like, no, but that's kind of the downside of using things that might be more palatable to them, because it's gummies, I think candy, and that's not really a good association to make there. Alyssa said, can you tell parents to use an actual measuring spoon like for baking? That would likely be more accurate, Alyssa. However, again, I would rather stick to using a dosing syringe if they can get a hold of one. And you could probably just go to the pharmacy, and even if you're buying like over-the-counter Tylenol for your kid, and just be like, hey, can I get a dosing syringe? And they'll probably be able to give you one. I don't think they're going to bat too much of an eye there, especially at places like Walmart or Publix, where they're trying to get you in there to buy other stuff anyway, so they're probably not going to be too upset about that. As long as you're not trying to go get like IV syringes, they're usually a little bit more touchy about that. But oral syringes, no problem. But yeah, that likely would be more accurate. But again, like who's making the baking spoons, or the measuring spoons? I don't know. How accurate is it? Do they calibrate it? I doubt it. So who knows? Other things to consider too, like drug food interactions. Like kids usually drink a lot of milk that can bind up with medications. You want to make sure they're separating those things out if need be. And then also consider things like inactive ingredients. So do they have dyes in them that the kids might interact with? Oftentimes we have to carry dye-free versions of a lot of our medications because of allergies, especially like certain red dyes, and things like that could also interact with the kid. So again, not just the med that can be a problem, it could be the other stuff that's mixed in with it as well. So whenever you're prescribing meds for these kids, it's really important to make sure that we get as up-to-date of a weight as possible. This can be challenging, especially if you haven't done their weight in a while and the parents may be working off of old information. So they said, okay, well, how much does your kid weigh? And you say, well, at their last visit, they were, 25 pounds. Well, when's their last visit? Oh, it was 8 months ago. That totally is not going to be accurate anymore for a lot of kids, younger kids. So make sure you get as up to date a weight as possible. Make sure you're checking with available references using the specific area that you need. So if it's a neonate, make sure you're looking at the neonatal section, right? And then when counseling kids, make sure to speak to their level. So, an infant, you're probably not going to be able to get a whole lot of education given to them. So you're going to be talking with the parents. But again, the parents may have the medical literacy of an infant. In some cases, they may just not know a whole lot. Or there could be language barriers and things like that you need to sort of get around. So things like interpretive services are really important. Making sure that, if they're older kids that have some agency, talk to them like they're going to be a participant in their own healthcare. That can help them help them have more buy-in and hopefully be more compliant with their regimen. So all that's really important and stuff you'll learn about as you're talking to real patients out there. But anyway, switching gears, let's talk about the opposite end of the spectrum here and get into our geriatric patients. All right. So basically geriatrics, we're talking about really anyone over 65 years of age. And again, we're having an aging population here as more of the baby boomers are becoming geriatric. I think a lot of them are. It's kind of interesting to hear about a lot of the societal changes sort of happening, especially like the distribution of wealth and the transmittance of wealth as a lot of these baby boomers are starting to pass away. And so it's kind of an interesting time for sure from that standpoint. But we are seeing a larger elderly population. And for most of you, you're probably going to be dealing with these patients quite frequently, as it turns out. So it's really important to do a good assessment for these patients. And again, I'm not going to tell you how to do a physical exam on an elderly patient. That's your guys' expertise. But I can tell you some of the things to think about when dealing with these patients from a drug standpoint, because you will find that whether you like to use medications or not, these patients are going to be on a lot of them. And so it's important to take into account different aspects in terms of their organ function, their ability to do things like activities of daily living, all these things that are going to factor into it, and seeing how well your medications are working, or what are the medications actually affecting here, which may be detrimental to some of these things, as we'll see here in just a little bit. So anyway, so again, we're going to focus on these elderly patients, especially those with a lot of complex problems, whether it be psychosocial issues, be from a complex medical history, things like that, and try to kind of get all that together to see, okay, what can we do best for these patients here, and what can we do in terms of helping to shore up, again, specifically here, their medication therapy. It's really important to take advantage of the interdisciplinary team because not everyone's going to have the same perspective, and not everyone's going to think of every single aspect of how to take care of this patient, right? So you can come to me and have me look at a elderly patient's profile, and I can give you some suggestions, but I'm not going to be thinking like a respiratory therapist is. I'm not going to be thinking about like a dietitian is. I'm not going to be thinking about how a PA will. So that's why it's important to get everyone's 2 cents, that we get closer to $1, right? And it's easier to have all your bases covered from that standpoint. Now, again, when you're kind of trying to make an assessment of a patient, look to see like what kind of activities can they do, or what has changed over the time period, because you may want to look at things like, well, since I initiated this medication, what has changed for them? Have their capabilities improved, or are they getting worse, right? You may see that, they used to be able to get up and get out and go gardening. That's what their favorite thing to do was, but now they're on this new medication, they're so tired they can't even get up and get out of the house now to do so. right? Those are things you want to be asking about. It could be as advanced as, can they go out and volunteer with their HOA? It's like, I always know my mother-in-law is like super active with their HOA and is always dealing with the gossip and the politics. That's pretty advanced activities of daily living versus something like, can she get up and go, feed herself? So it can be even as basic as that. And these are things you want to be assessing for. So from a nutrition standpoint, this is going to have a huge role to play in terms of medications, as we'll see here in a little bit. If they don't have good nutrition, you kind of don't have really the fundamentals that they're going to need for a lot of things that affect medications, as we'll see here in just a little bit. So poor nutrition intake can be a result of many things. So it could be things like poor dentition. It could be things like depression, or maybe even appetite suppressing drugs. I know I had one family member who's older who is on a ton of chronic pain medications, including opioids, and they never want to eat. They're just never hungry because it turns out they're super constipated all the time, right? So they just feel full all the time, never want to eat. It's led to some nutrition issues. They have dementia. They're not remembering to eat, or can they even feed themselves, right? A lot of times financial resources can be challenging here. A lot of times patients are on fixed incomes and are trying to decide, are they going to be able to afford their food versus their medications versus other things? And they may have difficulty even preparing their meals in the first place. So it's really important when you're asking these patients to get a good assessment for overall what their sort of general food intake is like. And you want to kind of get, what the kind of the average is, right? You don't need to know what they ate this morning, but on average, what do they generally eat? And think about things like food, drinks, vitamins, supplements, all of that for, a typical 24-hour period here. And again, look for things like, are they getting fiber intake? Are they getting, are they taking a bunch of vitamins and supplements that might be interacting with their other medications? Are certain medications being taken at the same time as food that can provide interactions, right? So for instance, we talked about bisphosphonates in the past for osteoporosis. Are they taking that at the same time they're eating their breakfast? Well, we know it's not going to work very well because the bioavailability is going to be terrible if you do that. So little things like that are questions you want to ask. In terms of alcohol intake, you want to ask about, how many drinks of beer, liquor, or wine they have daily, right? Now, again, this can be a tough question to ask because patients may not be accurate or may not be truthful. You can ask, okay, well, how many glasses of wine do you have a night? And they say, I only have one glass of wine, but that whole glass happens to be the bottle they just drink straight from, right? And it may not be totally upfront about that, and that's why it's good to ask the question more specifically. Oh yeah, what kind of wine do you like to drink? Or like beers are really important too, because you used to be a drink. Okay, well, what kind of beer do you have? And they say, oh, I just have a regular beer, and that's like 4.5%, 5%. But nowadays, if you ask someone, what kind of beer they have, they may say, okay, they have like some 10% double IPA. It's like, that's a lot different alcohol content than you would see for something like, Bud Light or something. So it's important to get more questions, get more details about that sort of thing there. Other things to ask about, like, how many over-the-counter medications are they using? When are they taking them in conjunction with the other meals? Weight loss, weight gain, things like that. I had one patient who we were talking to, it was a Parkinson's support group, and he was kind of lamenting over the fact that he had to move his egg. He couldn't have eggs and bacon in the morning anymore because of the fact that he was taking a Cinemet in the morning, and that Cinemet competes for the same binding sites as proteins do. And so he couldn't eat that at breakfast time anymore. He had to move it off because he needed a Cinemet to work. Otherwise, his Parkinson's would be sort of untenable. So again, little things like that we can ask questions about to see, okay, how well our medication is really working here. In terms of laboratory testing, this can reveal a lot of things for us. A CMP is very helpful. I always love doing labs and sims with PA students because we say, okay, what kind of labs do you want to order? And it doesn't matter if it's an ear infection, it's a broken bone, or meningitis. It's always CMP and CBC. Like, why do you need a CMP for an ear infection? But it's funny because that's like always your gut reaction, because it has everything on it basically, right? It's a complete metabolic panel. But again, you want to be a little bit more judicious. But for general assessment for an elderly patient, these can be useful because it will include things like their glucose levels and their kidney function, their liver function tests, electrolytes. All of these things can be wildly off for your elderly patients, which is why we like to check these semi-regularly. Looking at their lipid panels, A1C is really important for your diabetics, obviously. It's always funny when you have patients who will have their fasting labs done. They're really non-compliant, but they'll take their insulin like that day. So that way when they go to Quest and get their labs drawn, their glucose looks good, but then you check their A1C and it's like sky high. So it's like, okay, come on, buddy. We know what's going on here. CBCs can be helpful for looking at things like anemias, infection, obviously. Urinalysis can be useful too in some cases here. And again, we're looking at this in conjunction with their meds to see like, okay, or are the meds actually working? Are they doing what they're supposed to? Or maybe they're not being compliant with the meds, and that can be indicated by things like their A1C being out of whack, right? So for most of these patients here, you're going to see polypharmacy is generally the rule for a lot of them, and this is kind of considered to be the use of 5 or more regular medications here. The reasons why we're seeing more meds for these patients is because they're living for longer. As you live longer, you're going to develop more chronic illnesses, and because the guidelines kind of tell us, okay, if you have a heart attack or CHF, these are the meds you need to be on. If you have diabetes, these are the meds you need to be on, and so on and so forth. And so it's very easy to see patients getting on very intense regimens. So as an example here, you can see that a patient with osteoporosis, osteoarthritis, type 2 diabetes, hypertension, and COPD, is not uncommon, might be on 12 different meds at 5 times a day, right? I can barely take a multivitamin every single day. It's hard enough for me, and I'm a typical adult. Well, probably an atypical adult, but I'm an adult, I think. And these patients are expected to be keeping up with this, and they're elderly. It's really tough to do. Not only that, but like hospitalizations, like you don't go into a hospital and say, oh, you have too many medications on here, let's cut out some of these. No, they're usually adding on more medications, if anything else. And so this can be a big challenge, especially if you're working in internal medicine or family practice where you're kind of the main person that patient is seeing. You'll find that it's there's kind of a stigma associated with other people's medications, like when they're seeing specialists and things like this, that you never want to touch another person's meds. So for instance, they're seeing you for your general family practice sort of visit, and they're on a med that is causing a problem that was ordered by their cardiologist. A lot of providers are just going to say, well, that's their cardiologist thing. Just have them follow up with the cardiologist, say they want to do something about it, and they just leave it, even though they know it's causing a problem, right? They never pick up a phone and talk to that person because it's sort of professionally, sort of uncouth to step on someone else's work, right? So a lot of people don't take the time to actually call up and kind of chase that lead down for the betterment of the patient. But not you guys. You guys are going to be the ones that actually make that phone call, right? You're going to be talking to people. Other issues that can come about with polypharmacy includes things like adverse drug reactions. Falls are going to be pretty common with these, especially with a lot of CNS active medications, anticholinergics, antipsychotics, anxiolytics, antidepressants. All these things can work together to lead to hypotension or sedation or lightheadedness, and that can lead to falls. And especially with falls for elderly patients, that oftentimes leads to fractures, and that can lead to permanent disability. If we can prevent this, that's always going to be a good thing for them. And it can lead to decreased compliance as well, as you might imagine. So what can we do to what are some reasons why they have decreased compliance? Well, this could be related to complex dosing schedules, like we've kind of been talking about before. They're just on multiple medications, and it's hard to keep track of which ones they're actually supposed to be taking when. The economics of it are important. If they can't afford the medication, they're obviously not going to take it, so they're either going to skip doses or they may not get it all together, right? Maybe they don't have support that can actually help them keep them accountable and keep them on track with taking their meds. Mental decline is really important. Visual impairment can be affecting this as well. I remember I had one patient when I was doing rotations back in school back in the day. I had a community rotation as a Coumadin clinic and then a community pharmacy. And I had this one lady who came up, and she could not see more than 3 inches in front of her face. She was, by all accounts, blind. And so she had her medication bottles. She's getting refills probably like on 12 different meds, right? And on all the bottles, she had very particular symbols on top of the medication bottles. So one would have like a red triangle, another one would have a green diamond. And she said, hey, can you help me out? Can you transfer these tops to the new medication refills? So that way they keep track of which one's which. And I said, is this how you tell which meds you're taking? She's like, oh yeah, that's how I can tell the difference. And so I was like, there's no way you remember what a green triangle is versus a red diamond. It's like, she's like, no, you can quiz me. And I quizzed her, and sure enough, she knew every single medication. She knew how often to take it, when to take it. So, mentally, she was still sharp as a tack, just she couldn't see. But again, different components might be present for different patients here. Decreased ability to swallow things. Maybe the dysphagia from Parkinson's or something like that, or a previous stroke. They may need to switch over to liquid medications, for instance. And it's just like, what's their willingness to even adhere to treatment? Are they at a point in their life where they say, you know what, I don't really care about adding years to my life. I want to add, life to my years they have left. So focusing more so on the quality of life than the quantity necessarily. Anyway, so that's when we want to start to talk about the specific sort of organ changes that occur in elderly patients as they get older. So some of the things we can expect to see. Cardiac function, certainly going to see loss of left ventricular ejection fraction over time. Reduced heart rate, certainly blood pressure typically will increase for a lot of these patients here. From a renal standpoint, you're going to see a decline in renal function. That GFR is going to go down. We just know that's going to be the case here. And also their decreased ability to maintain acid-base balances. That's why it can be really challenging for a lot of patients, especially those that are elderly that become septic or something. They become very acidotic, and it's difficult for them to counteract that because their kidneys just aren't able to really maintain that acid-base status like it normally would. Here's an example, just some of the decline in function that you're going to see here. And some of this may not be present for quite some time. We typically have a lot of reserve function in our organs. And it's not until maybe we get down to like, say 50, 40% left before we really start to see things manifest, things like, GFR declines and things like that. So we know it's going to happen. We need to take that into account, right? Especially as the years go on. And one other problem I see frequently, especially with chronic management of elderly patients, is that no one ever goes back and rechecks their organ function. So if they go from age 60 to 70, they're going to have a decline in their renal function. But if they're on the same dose as they were when they're 60 as they are now at 70, that may not be appropriate anymore. But again, they've just been on it for a long time. If it's not broke, don't fix it. And they never go back and check. That can be a problem. So other things we can see include from a gastrointestinal standpoint. For the most part, not a lot of changes here. You're going to see maybe some decreased motility. You may see slowed absorption of medications, but overall total absorption should be about the same, same here. Probably going to run into, though, is more so just their drug interactions, drug-food interactions. It can be interfering with their ability to absorb those medications, right? So, for instance, they're taking grapefruit juice, or not grapefruit juice necessarily, but they're taking like calcium-containing dairy products with, their iron tablets or their fluoroquinolones or something like that. They can bind up pretty easily and prevent absorption from occurring there. From a liver standpoint, what you're going to see is that decreased blood flow through the liver can be a problem, especially if they have those like CHF or something. They have like hepatic congestion. If you're not getting as much blood flow going through the liver, you can't present as much drug to the liver to be metabolized. So overall, half-life of the drug can actually be extended in some of those cases there, which is kind of interesting. As I mentioned, overall, you should not see a lot of changes in absorption for these patients here. But again, look at things like dietary changes. Look at the OTC medications they're using. Are they using antacids now to deal with some of their GI complaints, and that's interacting with some of their meds? Sometimes you may have things like impaired gastric emptying. That's usually with diabetic patients with gastroparesis, but again, this may be dependent on the patient there. From a distribution standpoint, typically these patients will have reduced lean body mass. You're going to see overall the fat content's going to go up, muscle content will typically go down, and you can see changes in total body water going down as well. So what this means typically is you're going to have a higher volume distribution for lipophilic medications and lower volume distribution for hydrophilic medications, generally speaking, right? You may find, some of the older patients that are like, bodybuilders or something, but this is, generally the rules that we're talking about here. So again, that can affect your medications pretty significantly. It's kind of the opposite of what you end up seeing with infants to some degree, because there they have too much body water. Here we're going to get less of it, and again, more fat mass and less muscle mass. And so this is going to have a role to play with a lot of different, in terms of how drugs are distributing, where they're going to be going to the tissues versus they're going to hang out in the bloodstream more, potentially cause toxicity, right? In terms of protein binding, they can affect, again, the distribution of medications. You can see things like decreased serum albumin levels can be important here. So for instance, like phenytoin, 90% protein bound albumin most of the time. If you have decreased albumin levels, say due to chronic malnourishment, some of these patients, you're going to have a higher free fraction, right? So maybe it goes from 90% to 80%. When I've doubled the amount of free phenytoin in the body that can interact with the CNS, it can lead to dizziness, falls, and a fracture, right? So overall, this is mostly going to cause increased free fraction of drug that's available to the tissue, may predispose them to toxicity. In terms of drug clearance, you're going to see reduced clearance for the most part. However, this may not always be apparent when you do your drug dosing calculations or when you do your GFRs calculations here. This is mainly because their change in serum creatinine is not proportional to their decrease in creatinine clearance. Okay, what that means is they are unable to produce as much serum creatinine as they would normally, and thus that can cause their creatinine clearance to be falsely overestimated. So I'll give you an example. Imagine you have a patient who is, say, 80 years old in the ICU. Maybe they're like 90 pounds, and the creatinine comes back and it's like 0.5. And you're like, wow, this patient's renal function looks really good for an 80-year-old, right? Well, they're like 90 pounds. So like the problem is that they don't have any muscle mass to produce a creatinine in the first place. But while you're looking at that creatinine at 0.5, you're like, wow, it looks pretty good. It's really not. It's really, if they had typical muscle mass for someone, they had more muscle mass, they'd probably have a whole lot higher serum creatinine. So it can be kind of falsely making you overestimate the renal function. You get too aggressive with the drug dosing unless you cause toxicities, right? So again, you want to be really careful with that because overall, someone who's 80 is probably going to have some degree of kidney dysfunction, just guaranteed, right? This can lead to prolonged half-life of drugs, more toxic concentrations, and again, highly affected by their hydration status. I cannot tell you how many times you'd have elderly patients coming in from a nursing home who probably got like a cold or something like that. No one was really watching them as close as they probably should have been. They get dehydrated, and then they get really high drug concentrations. They come in for drug toxicity, right? They've been on the same dose for years, but no one caught that they were getting dehydrated, and that led to some severe cases. For instance, I had one lady who was on theophylline for COPD for decades probably, and no one caught that she was getting dehydrated, and her renal function had diminished pretty significantly. She ended up developing seizures, came in, and she died from that, right? Because of just this one-time sort of event that happened here. So this is why it's really important to make sure these patients stay well hydrated, which may be difficult if they're like in an assisted living facility. So drug clearance, as I mentioned, in terms of liver function, this may be diminished, especially if you have things like hepatitis and alcoholic cirrhosis and things like that. Overall, you're going to see decreased function of some of these enzyme pathways, which may lead to less first-pass metabolism and thus better bioavailability, which can be some cases there. However, you may also see, as I mentioned, that decreased metabolism just due to the fact that you're not processing as much blood through the liver. So in that way, you actually see better absorption, better bioavailability, and also longer half-lives of the drug if they cannot be metabolized in the liver. So again, something to consider with that. So, those are kind of the kinetic differences that happen here, but let's look at the pharmacodynamics of the drugs themselves. I had a question. Someone said, if a patient is taking a med without any side effects, but their renal function or whatever has gone down over time, would you still adjust the dose? And how do you balance decreased organ function and patient tolerance? That's a great question. So you have to kind of look at it from, one, don't just look at the number, look at the patient overall, right? Looking at things like, for instance, let's say I'm trying to think of a good let's look at lithium, for instance. Say a patient had a bipolar disorder for a long period of time. They're on lithium. We know lithium has a narrow therapeutic index. We know it's pretty tightly maintained, usually between 0.6 and 1.2 milliequivalents per liter. And so say a patient's been on it for a while, and so, okay, everything looks good, don't want to change the dose, but you go ahead and get a level anyway. And say normally they're sitting at say a 0.8 or something like that, and all of a sudden they're like 1.1. Patient's still not having any toxicity from it, but you're like, okay, well, they're kind of pushing the edge here a little bit. I know that even a small difference in renal function could lead that to go over pretty significantly. So in that case there, you may want to consider readjusting their dose down to get back to what that normal level for them would be and see how do they do, right? So see if their symptoms come back or whatever the case may be. But again, at least you're addressing it, you're looking at it instead of just saying, okay, well, everything's fine, no point in checking it, right? Because the problem is no one ever goes back, looks at that renal function, looks to see if that level has changed over time. Because again, these patients are really sensitive to those small changes in things like hydration status, as opposed to like an adult patient, younger adult patient might be. So again, yes, you may need to still adjust that dose, but it's going to be on a very case-by-case basis. But at least you're looking at it and you're doing something with it, right? The problem is most people don't look at it. Someone's an unrelated question for the end of lecture. How long will I have access to your vids? I would love to rewatch them over rotations. Not sure if you plan to delete them. I don't delete anything, so everything is up there. I think I have, I don't know how many videos I have up in total, but I have hundreds, I believe, at this point. So, feel free. You can go back and watch whatever you like. If you need a natural cure for insomnia, this will also be pretty good too. So just FYI, if you ever need that. Anyway, let me get back to the lecture itself. All right. So anyway, so the question like with the pharmacodynamics is like, are these elderly patients really more sensitive to the meds? Oftentimes it's not. It's more so the fact that they're just going to be, they're having these pharmacokinetic changes that are leading to much higher levels than you'd expect to see in a younger adult patient here. And other things that can happen too is they have these kind of lessened homeostatic responses. So imagine if you were a typical young adult, you go from a sitting to standing position, your blood pressure does not really fluctuate that much because you have good reserves. You're able to maintain good cerebral blood flow, no problem. You're not going to get dizzy and fall over. For elderly patients, that may be much more of a problem. They may not have the ability to really respond to those sort of sudden changes quite so well. Not only that, but you can also see things like cardiac output may not be changing as quickly, postural hypotension, as I mentioned, temperature regulation. A lot of older patients typically feel cold all the time. I know I was really concerned when I went home to my parents' house and I was like sweating in their house, and I go, what is going on here? Why is it so daggum hot? Is because like to them they're cold all the time, so their house at 78 degrees was like toasty to them. They loved it. I was like sitting there sweating buckets. So I was like, oh no, my parents are getting older. Time's cruel march continues on, but something we gotta deal with. Things like fasting plasma glucose typically goes up over time. So anyways, I want to talk about some of the specific drug classes, and we've been kind of talking about these throughout the year. So some of these will not be too big of a surprise to you, but just to highlight a few points here. You always want to be really, really careful with patients who have sedative hypnotic drugs or analgesics, especially if you're starting them up in these patients here, because they can really throw them for a loop. Mainly because you can find things like benzodiazepines, antipsychotic drugs, anything that's sedating may have an extended half-life in these patients. They may have active metabolites they're not able to excrete as well. And so overall, you can see that they can have pretty dramatic effects from this. It's not that they're more sensitive, they're responding to the drug differently. It's just they have a lot bigger buildup of levels than you see for a younger patient. And this is a big cost for ataxia, falls, ultra-mental status. You're like, man, grandma's really getting demented, but really it's just the medication that was started on them. They're not able to clear it out as well. Opioids tend to be a problem too over time. For certain ones, for instance, like morphine, you can see buildup of active metabolites that may lead to more toxicities like respiratory depression or CNS depression, right? Some of these things they do get tolerant to over time, but again, it is very dependent on the situation. Sometimes patients' medications may be fine when they're at home, but then you put them in the hospital setting, they start to sundown. I'm not sure if anyone's ever witnessed that, but it can be tough when you put elderly patients into a new environment, especially around evening time. They tend to get a little loopy, sometimes even kind of anxious and aggressive, and that can be exacerbated by some of the meds that they're on as well. With things like lithium, this can be really challenging because it is so dependent on renal function. So even small changes in renal function may lead to big accumulation of lithium in those patients. Or say you start them up on a diuretic for their CHF. All of a sudden now they're going to be in a sodium retentive state. Now they're going to have higher lithium levels, for instance. So again, you got to be really watching that one very carefully, and I'd probably avoid it in elderly patients if you can. Antidepressants, typically a lot of the older ones like your TCAs and whatnot, lead to a lot of things like altered mental status and falls and things like that. So things like SSRIs and SNRIs are typically much safer. So you probably want to stick with those for most of your elderly patients there from that standpoint. From a cardiovascular standpoint, we can see here the antihypertensives can cause quite a few problems, especially things like your, direct vasodilators like your calcium channel blockers. Things are decreasing cardiac output like your beta blockers. All of that can increase your risk for orthostatic hypotension. That's why most of the time, again, you want to start low and go slow for a lot of these patients here and gradually work them up to kind of their standard therapeutic doses. A lot of times we'll also give these medications at nighttime when they can kind of sleep through a lot of those effects. And that way, by the time they wake up in the morning, they've kind of taken the brunt of it already. And that way, by the time they get up, they are not going to sit there and just fall straight over, right? Diuretics you want to be careful with because of the fact they can cause a ton of electrolyte disturbances. That's another thing you want to watch out for, especially if they are on any sort of antiarrhythmics, because we know that can then exacerbate that, lead them to be more likely to develop, arrhythmia in the first place. A lot of antiarrhythmics are going to have extended half-lives, so again, you have to be watching out for their organ function and to make sure you're adjusting for that appropriately. Again, when you're looking up stuff like an UpToDate or LexiComp, they'll have specific sections that their organ function is like this, and then dose them like this. Renal function, hepatic function, whatever the case may be. And again, these patients are going to be developing more adverse drug reactions. We know the more drugs they're on, the more drug reactions they're going to be potentially getting. By the time they're on 10 medications, they're probably experiencing a side effect already, even if they don't know it. A lot of times, if you don't tell them what to be looking out for, they just may not know that's a side effect. So, some things are pretty obvious. You give someone rifampin, they're going to have red urine, right? That's pretty obvious there. But, it could be something subtle, like I can't really get around the house as much as I used to. I must just be getting older. That's a beta blocker you put them on. They don't really have as much exercise capacity as they used to, right? So again, explaining to them the side effects they can expect to see are really important for these patients here. Not only that, but they could be taking a lot of OTC and herbal medications that you are completely unaware of, especially if you never asked the question. I'll tell you, one lady who came into the ER for stroke-like symptoms. She was on warfarin for atrial fibrillation, and then she was, concerned about her memory, and so she started to take ginkgo biloba for that, dietary supplement. And so no one told her, or she never asked anyone, that ginkgo actually has anticoagulant properties as well. So the reason why she's coming in for stroke-like symptoms is because she had a massive hemorrhagic stroke due to the combination of both her warfarin, which was in a therapeutic range, but also the ginkgo adding on to that as well. And so she ended up dying from that. So again, these OTC and herbal meds are no joke. Like, they can cause significant effects here. So you always want to be cautious whenever someone says, oh, that herbal stuff, it doesn't do anything. It can do some serious stuff, including side effects. So you got to be really careful with that. Make sure that you're asking the questions. Make sure to tell your patient, hey, if you want to start taking some kind of herbal supplement, ask me first, because we can make sure it's not going to interact with the medications, right? Go with an open and honest sort of conversation instead of being judgmental about it, and they're more likely to ask you questions and come back to you, and you can kind of circumvent problems like that. Now, prescriber errors happen all the time. Nobody is perfect, as it turns out, with even your medical providers. And so you need to make sure you're taking into account age-related changes that have occurred. Again, you may be seeing a patient for the first time, but they've been managed by the same person for 10 years, and no one's ever gone back and adjusted their meds. Go back and see, is that stuff still appropriate? Do you need to be adjusting that to take into account kind of what changes they're experiencing? You may run into patient compliance errors, and then I also talked about the multiple providers. If they're seeing a psychiatrist plus their cardiologist plus their endocrinologist plus you, it's a lot of different, a lot of cooks in the kitchen, so to speak. And so it's important for you to, if you're that central person, to be able to say, hey, wait a second, let's stop. Let's kind of take another assessment here. Let's talk to these different providers and see if we can come up with some kind of plan. Because again, a lot of people don't want to step on other people's toes, and that can lead to patients being on some very wacky regimens that make no logical sense, but no one ever wanted to, stop anything else because that was some other provider's, prescription. Now, how do we keep compliance up? There's a lot of different ways for patients to remember to take their meds. Here's an example of a pill minder. That way, everything is just kind of put into specific boxes here. So they know, okay, Monday morning, this is what I take. This can be really challenging, especially with, kids going over to grandparents' house, because I can't tell you how many calls at the poison center I would get where, they say, oh, little Johnny got into Wednesday morning and Thursday afternoon. And I'll say, well, what were in those boxes? And the grandparents are like, I have no idea. Someone else does this for me. It's like, okay, great. And I have no idea what this kid actually got into, So that can be pretty challenging for sure. But it's helpful for them to at least remember to take their meds. Nowadays, there's a lot of apps and things like that, alarms. But again, depending on how technologically savvy your patient is, they may be more or less, adaptable to those sort of things there. Now, again, there's a lot of reasons why patients may be non-compliant. Medication expense is going to be a huge one. Most of these patients are on very limited fixed incomes. So while the drug rep might have come by and took you out to dinner and told you how great this new NSAID is and how well it works, if it costs hundreds of dollars and your patients can't get coverage for it, then it's not going to work that well for them, and they can take something cheaper, right? And if they can't afford a med, then they're just not going to take it, right? Medications with mixed dosing intervals can be really challenging in order to keep the regimen, just from a scheduling standpoint. So try to, use combo drugs whenever possible. Try to make sure you keep things as simple as you can. And then sometimes there's intelligent non-compliance. So for instance, if, somebody is just like, man, this medication just gives me really bad headaches or constipation, I'm just not going to take it. And then they come back to you and you're saying, well, how's the medication work? And they're like, it's fine. And you're like, you're taking it like you're supposed to? And they say, yep, definitely. Patients are not always going to be truthful. I don't know if this is the first time you're hearing of this, and it may be a bit of a shock to some of you, but patients may lie to you. And so that can be a challenge as well. and consider, can the patient even physically take the drug, right? So, do we need to be adjusting dosage forms? Do they need a liquid form? Do they need a patch? Something like that, in order to ensure their compliance is another consideration as well. So that's it for this section. So kind of a brief overview of kind of the things to think about when dealing with pediatric versus geriatric patients here. Next week we're gonna have our final, and we get your last prescription assignment graded as well, and then that's it for the course. So what questions do you all have? I open the floor to you. Or if you have no questions, you can go. Either one. Thank you for hanging out with me for the semester. I know it's been for the 2 semesters, I guess. This has been good doing this live. I think it's probably been better, hopefully better for you guys than pre-recording everything. So it's kind of a one side benefit of being at home for the pandemic. So I know it's been early, but yeah, thanks for joining me on these 8 o'clock sessions. Oh, well, thank you, Julie. I really appreciate that. You guys are very nice. Again, the videos are up here forever, so, or at least until, I don't know, YouTube goes down. So if you ever want to go back and check this stuff out, feel free. I mean, I got plenty of years of all the others. I'd leave everything public, so you can look at all that stuff and see all the goofy things I say. Yeah, see you guys around. If you have questions before the exam, feel free to email me. Again, the earlier you reach out to me, the more likely I am to get back to you. So earlier is better. If it's 3 a.m. before the morning of the exam, I'm probably not going to get back to you. So, oh, thank you, Kayla. That's really nice of you. I appreciate that. It's a very high compliment because I know you've had lots of professors in your day, undergrad and all that. So I'm very happy anytime someone tells me that. Very nice to hear. Always try to be the professor I would want to have if I was in school. So, all right. So I don't see any questions. Yeah, you guys are awesome. And yeah, feel free to reach out if you have, even if you have questions that come up on clinicals. Feel free to reach out and ask me a question or something like that. Just because you're not taking my class doesn't mean I can't still provide some sort of knowledge to you. So you guys got my email address, so you can always reach out. So all right, I'm gonna end the recording here, and I will see you guys maybe out there in the real world. Who knows? This pandemic's all over, but I'll see you guys in the future. Have a good one.